I have the honor now to introduce Dr. Laura Van Veer, the recipient of the 2024 William L. McGuire Memorial Lectureship. Dr. McGuire founded the San Antonio Breast Cancer Symposium in 1977 together with Dr. Charles Coltman. The William L. McGuire Lectureship was established in 1992 to commemorate the significant contributions of Dr. McGuire to cancer medicine. His research played a major role in introducing the estrogen receptor assay on breast tumor tissue as a guide to treatment. Breast cancer patients everywhere now receive this test. Laura Van Veer is professor and the Angela and Shu Kai Chan Endowed Chair in Cancer Research in the Department of Laboratory Medicine at the University of California in San Francisco. She's also the Director of Applied Genomics and leader of the Breast Oncology Program for the Helen Diller Family Comprehensive Cancer Center at UCSF. She received her undergraduate and master's degrees from the University of Amsterdam, her PhD at Leiden University, and a postdoctoral fellowship at the Massachusetts General Hospital, Harvard Medical School in Boston. Dr. Van Veer was selected for this award for her trailblazing work in advancing risk stratification, subtyping, and improved treatment for early breast cancer through the invention of MammaPrint, a laboratory test that predicts breast cancer recurrence by quantitating 70 genes in breast cancer tissue. She's also responsible for building the scientific platform for the nationwide I-SPY 2 trial. Her persistent and focused efforts since the first I-SPY trials were launched have led to the development of a valuable biomarker bank of clinically annotated tissue and blood samples from over 30,000 high-risk breast cancer patients. Dr. Van Veer has been honored with numerous awards through her career, including the OncLife Giants of Cancer Care Award, the European Cancer Organization Clinical Research Award, the Breast Cancer Research Foundation Pink Ribbon Grant Award, the European Union Prize for Women Innovators, the European Society for Medical Oncology Lifetime Achievement Award for Translational Research in Breast Cancer, and the International Agency for Research on Cancer Medal of Honor, among many others. Please join me in welcoming Dr. Laura Van Veer to the podium.
Thank you. Thank you so very much. I would like to thank the San Antonio Breast Cancer Symposium and its co-organizers, the University Texas Health, and the AACR for selecting me for this very distinguished award. I'm happy to give a presentation today, show you what work has led to all of this today. These are my disclosures. The topic of my talk is breast cancer diagnosis and what treatment. When disease is localized, it's mostly curable, but when it's generalized elsewhere in the body, it's very difficult to cure. There are medical therapies that prevent recurrence, but there's risk of over-treatment, under-treatment, and suboptimal. So today I'll show you 3 examples how molecular diagnostics can guide clinical decision-making. The first topic is low risk versus high risk of recurrence and the need for chemotherapy. We discovered that 70 genes expressed in the primary breast tumor could distinguish high risk from low risk recurrence tumors. And those patients with a good signature may have a low need for chemotherapy, and those with a poor signature, a high need for chemotherapy. It was when this finding was published that I got a year later a call from Martine Picard, who asked me, are you interested to do a prospective clinical trial based on these findings? I just started as a PhD in the clinic, and let alone I'd never done a clinical trial, but we did it, and our collaboration has been very joyful ever since. The main question of this trial was to see if those patients that are clinical high and genomic low, as indicated here, and were randomized to no chemotherapy, had a good outcome and could safely forgo chemotherapy, therefore. So the outcome of the trial was very good, and we showed indeed that the primary endpoint of 5-year distant metastasis-free survival was met, and also with the required confidence intervals. We also, the secondary endpoint showing that the difference in the other group of patients who did get chemotherapy at 5 years was less than 2%. That was also met. Of course, there's always new things to learn. So at the 8 years, or actually 9 years median follow-up, we stratified patients in those being diagnosed before age 50 or above age 50. And what did we see? There was indeed those that were deemed postmenopausal, really no difference with or without chemotherapy. And the recommendation is indeed today safely to forgo chemotherapy. On those diagnosed before age 50, there was a non-statistically, but as Martine Picard said, clinically interesting 5% difference. And so that is still a discussion ongoing whether these patients who get more intensive endocrine therapy or indeed chemotherapy, and there are several trials worldwide currently studying this. So with all of this work over the years, the 17-gene MammaPrint test was included in many different treatment guidelines and also is reimbursed in many countries across the world. My second part of the talk is to look at those patients that actually have a late low risk of recurrence. So those have a risk after 10 years. And are those the ones that may need extended hormonal therapy, which is sometimes used? So for whom is the benefit of extended endocrine therapy? So 5 years of endocrine therapy is the standard for almost everyone. The extended therapy beyond 5 years, total of 10, is optional. The benefit shown in clinical trials that study this is modest and is accompanied by increased adverse effects. Some patients may be more likely to derive benefit than others, and there is a risk for increased adverse events. So we looked again at 70 gene scores in the low risk side. So there you can distinguish a group that has a very low late recurrence, really almost only a few %. And then there is a group that has a low but not ultra low risk for late recurrence, as we established studying trials from the Stockholm group. So in this late recurrence group, if we look for those that are MammaPrint low risk but not ultra low, we first did that in the NSABP B42 trial. This is a trial that studies 10 years endocrine versus 5 years endocrine therapy. And what you can see here for several of the endpoints, that the benefit is in this low but not ultra low subgroup. And this was published recently by Rastogi in JCO. We then also looked at the ideal clinical trial, which studied 10 years of endocrine versus 7.5 years of endocrine therapy. And here you can also see that I'm showing you just the data of the MammaPrint low, not ultra low, that there's a benefit of 10 years versus 7.5 years. So this was a confirmation in a second trial. So the summary of that data is that in high risk, there is no significant benefit. But it's maybe understandable because the risk of recurrence is early. So why treat after 5 years? Those that are ultra low risk, their risk continues to be very low and they have excellent prognosis and may not need that. Then there is this middle group, MammaPrint low risk, non-ultra low, that do derive the benefit, which is a 4 to 12% absolute and over 50% relative risk reduction. So that was both published, as I said, in JCO and the other one just last week in JAMA Network Open. My third example is early stage breast cancer and those that are high risk for recurrence. Because we just said they benefit from chemotherapy, but actually look into the details that only 1 or 2, maybe 1 to 2 benefit 20 to 25%. And of course, there's the opportunity now for new targeted drugs, but they need companion diagnostics, because giving them to everybody makes not real sense. So for that, Laura Esserman, she is the principal investigator for the I-SPY 2 breast clinical trial that enrolls patients with high risk for early recurrence. And among you in the audience, there are 45 other sites that actually are also enrolling across the United States. I'm overseeing the work on the biomarker as a co-principal investigator. So the I-SPY 2 platform design and lessons it's a neoadjuvant trial for molecularly high-risk stage 2 and 3 breast cancer patients. It's a first block, as you can see in the diagram, of paclitaxel followed by, combined with the targeted agent, followed by AC. It has become the archetype of an adaptive platform trial. The primary endpoint is PCR, and since 2010, 23 agents were tested across 2,117 patients who were evaluated in the efficacy analysis, and 10 of those agents graduated with a predicted high success of a confirmatory phase 3 trial. One of the two maybe examples, one is pembrolizumab, first shown in I-SPY to work for high-risk breast cancer patients, and the other one was the pertuzumab arm for HER2-positive breast cancer patients. So PCR is really an important endpoint. This is across 950 patients, and this median follow-up 3.8 years, and we're still counting and doesn't really change much. You can see all patients with a complete response at surgery, they're 95% recurrence-free. And we're counting, and it's going really well. Though patients without the complete response, they have a higher risk for recurrence. So PCR matters regardless of what drug, whether it's the control arm or the arms where a targeted drug was added. In I-SPY 2 and now I-SPY 2.2, which I briefly will discuss at the end, we're testing drugs that block the derailed tumor biology. This is everybody's most famous diagram of the hallmarks of cancer, and you can see that on many of those hallmarks, there are whole lists of drugs that have been tested in I-SPY. And I-SPY is asking, what is the response if you add targeted drugs, and actually for what subtype? So to date, and I looked at it yesterday, 5,000 patients have been screened. I didn't look today because I wanted to keep it at 5,000. There are 3,100 patients enrolled, of whom 20 to 25% have a diverse race ethnicity. So far, 30 targeted drugs or combinations have been gone into the trial, and 5 of those are still ongoing. So first of all, in I-SPY 2, with those 2,117 patients, we used standard biomarkers. As you can see here on the left, the standard receptors, subtypes like hormone receptor positive, triple positive, HER2 positive, triple negative. And just to remind you, everybody is MammaPrint high risk for recurrence. So I'll give you one slide of an overview of all treatments, first 9 drugs in I-SPY, but it actually doesn't really matter if we look at all 23 drugs. So by subtype, as you can see here, so the HER2 positives actually have the highest with a THP drug. In the triple positive, TDMP and THP are the winners. If you actually split these one in the real HER2s and the real actually more luminal, you start to see the difference as you see here. Triple negatives, it was pembrolizumab that did the best. In the hormone receptor positive, pembrolizumab was the only one who did some increase, but not really much. So we actually then went to our system of qualifying biomarkers. Can we more precisely identify responders by looking at the mechanism of action of the drug? And so we tested that first across those 990 first patients in the trial, and later working on all of the validation of that. This is like a huge undertaking, and without Denise Wolf, Christina Yao, Jill Hurst, and Lamorna Swigert, we would not be able to actually manage this. People from within the network, outside the network, can propose proposals, and we help them actually to access either already generated data, or if they have a brand new technology we're very interested in, they get access also to the tissue. We have a data access and publication committee who oversees that. I cannot go into the details, but you can read that in this paper published in Cancer Cell in 2022, we yielded 6 response predictive subtypes out of all the knowledge of biology of all these investigators. An immune oncology modulation, all those investigators helped us what is the exact biology that we need to identify such a type, or DNA repair, or 2 types with HER2, or there's a group with low response to anything or actually to nothing. So how does it look like? If you take the first 10 arms of I-SPY, and you look, of course, over time, patients did not all get their best I-SPY drug, because in the beginning there was no immune oncology drug. So this is the best I-SPY drug if they would have gotten access to that right from the start. So for instance, if you take triple negative, which is over 1/3, 6 in 10 response would be the best drugs, and I can disclose to you that's of course an immune oncology drug. Hormone receptor positive, 3 in 10, and the HER2 positive subgroups are pretty good. If we rearrange by this Sankey plot, as it's called, the subtyping of these 990 patients into the response predictive subtypes, and again look at what would be the best drug we can think of for each subtype, you can see those here, for instance, the immune subtypes, and really see that triple negatives, not everybody is immune, it's a large subgroup. And the other remarkable thing from the hormone receptor positive, there is a considerable group that's actually also immune sensitive, as we established. So how does it look like? If we first look at these bottom 4 response predictive subtypes, in the immune sensitive subtype, if we model that, we predict 8 in 10 would have a response. DNA repair, 8 in 10. In the dual targeting, either 8 in 10 or 6 in 10. But in the top group, we're a little bit worried because these patients who have a biology that is not immune sensitive, not DNA repair, there's a 1 in 10 response. So clearly, we need what to do here, and we actually need help and are working on this. I want to give you one example in more detail, which is the immune sensitive subgroups, and as I show here, which consist of the triple negative as well as the hormone receptor positive, HER2 negative group. So in I-SPY 2, we tested 9 immune oncology arms, and you can see here all the arms over time that went through I-SPY 2, most of which showed a 2 to 3-fold improved efficacy relative to control in the hormone receptor positive and triple negative respectively as it was given during the trial. So we used 5 of these arms to build a predictor based on the biology as published in that Cancer Cell paper, and looked for the response biomarkers. So here is the overview of those 5 immune oncology arms in I-SPY and their actual immune oncology efficacy. So the 5 IO arms in triple negative have 54% response, without it 26, and those subtypes that are hormone receptor positive have a 33 versus 13. So that's in the trial a really good success. But not everybody responds. So why do we want to know who responds? Immune oncology agents carry a risk of immune-related toxicities. I-SPY has a very detailed program in monitor many adverse events, and it was noticed that there are actually some very serious, non-reversible. They're rare, but they're non-reversible. So therefore, we want to understand who really benefits from these drugs and who maybe could better be treated by another treatment. So we need predictive biomarkers. So based on the immune biology, as I showed you, we developed this signature together with Arteaga, which is called imprint. So if you look at all triple negative patients in I-SPY 2, 2/3 are imprint triple negative positive, 1/3 positive, 1/3 is negative. If you then look at Deer in an independent test set after we had developed the signature, there in those that are imprint triple negative positive, there is a 71% response, and in negative a 22%. So if we look at in the hormone receptor positive group, there's a lot of discussion who within hormone receptor positive should get an immune oncology drug. I tried right in the beginning to steer that toward biology, but so far not yet successful. But in iSpy, we have been looking at that in detail. So here only 26% is imprint being immune biology positive. And that group has a 74% response versus 19% in the controls. So in conclusion, in the summary of this part, the imprint positives, the PCR rates in those that get IO regimens is very high, over 70%. Imprint negative, the PCR rates are very low and similar to the non-IO containing regimens. There are many details you can ask me questions about, but this is the overall conclusion. So this could help to prioritize who should really get such an immuno-oncology drug to best balance benefit versus risk of immune-related side effects. We're not at the end of this yet, but that's the next thing to study. That is what we study in now what's called iSpy 2.2, and I'll walk you through this in 3 slides. So iSpy 2.2 is the iteration of iSpy 2 since June 2022, and it uses a sequential multiple assignment randomized trial. This is called SMART design. And the goal is to maximize the chance of reaching a PCR for each patient and avoid overtreatment. 608 patients have enrolled since June 2022, so it's going fast. So it's really, the key features were from this whole group of physicians that is hard working on all of these parts of the trial to use the response predictive subtypes to actually evaluate in block A, as shown here, just an investigational agent without the standard of chemo. So it could be a drug-conjugated chemotherapy, antibody-drug conjugated chemotherapy, or an IO. But then assure patients, and maybe their physicians, that they have 2 additional shots on goal with subtype match best treatments and rescue chemotherapy. So that would be in block B. So if you are immune positive by your biology and you didn't respond in block A, you get it in block B. So it also, of course, everybody is just giving such a experimental therapy, everybody is a little bit nervous. So there's an early escalation if people really don't respond in that first block, and they can go to the next block early. Or there's a de-escalation where patient, and to actually prevent that you get unnecessary treatment, to go to surgery early. This de-escalation is based on the predicted residual cancer burden. So there's an algorithm that patients who have at 12 weeks really no tumor seen in the MRI, by a more elaborate algorithm than this picture, of course, and there is a no invasive cancer in the biopsy, they can go to surgery early. We're currently testing if adding ctDNA would even improve that prediction. So these data that I'm going to show you was recently presented at ESMO, and it's both published, 2 articles published in Nature Medicine. I'm showing you one example, which is the DADO deruxtecan antibody conjugated chemotherapy with durvalumab, which was given for 4 cycles in block A without standard chemo. So 33% of patients qualified to surgery after block A and skipped the traditional chemotherapy. And if you looked at those that were immune sensitive predicted by imprint, that percentage went up to 43%. And the toxicity profile was manageable. Then if you look at, so what I just showed you was just block A, that first block, as you can see here. So after first block, those that are immune sensitive do have a very high response, and if they don't have any of that biology, there is no response. Some patients will continue to go on the block B and C, and then the percentage of response goes up to almost 80%, as we predicted. So the biomarker works. What did we see for this particular drug? If patients continued in the next 2 blocks, they actually showed a response. So they don't have any immune biology, not DNA repair, but somehow the first block triggered that they could respond in the second block. So many of you may work in this area. We're happy to work with you to understand what is actually going on here. We're happy for these patients, but it seems that some way we can activate a response. So in iSpy, the right drug for the right patients, we're used to stratify by receptor biology. I actually think and want to plea that we should look for drug response subtype. That would much better balance the efficacy and toxicity, which we are testing in I-SPY 2. There are many, many patients involved and many pharma companies and biotech. I've added their acknowledgements in my slides. You can at leisure read all their names, but I don't have time to read those all. So 20 years of progress. Low risk, 45–50% of early breast cancer, no chemotherapy needed anymore, or at least the recommendation is that. Late risk, we may get to extended endocrine. Of those high-risk patients, actually 20% is really high risk if you take a general breast cancer, first early breast cancer population. They're good targeted therapies with 60–80% response. We still have to look in what to do for the non-responders and the young age. And just to reassure you, we won't forget metastatic disease. We just had to build up our whole collection and our thinking. So we're going to move there next soon. The acknowledgements. For my work, 70 genes at the Netherlands Cancer Institute and Arteaga already named some of these people. They helped me to actually make such a research finding a diagnostic test, which nobody had done in a lifetime anywhere before. The MINDEC trial that helped to prospectively validate this, and the I-SPY trial, many people are very active in that and want to mention our sponsor, a non-profit Quantum Leap Healthcare Collaborative, and many other people. So I want to actually end with some personal acknowledgements. First of all, I want to show you my parents. They were both journalists. These are pictures from them, photos from long before I was born in the 1940s. They were actually traveling the world to report on political changes that were going on in Indonesia, becoming an independent country. They did that both in Indonesia itself and later through the United Nations work at New York, before settling in Amsterdam, and several years later I was born. My group of family friends, whom I have since my student time, and we have been a bigger and bigger family with now 3 generations, a group of 25 to 30, where we have been going to Schiermonnikoog. Many people know me saying something since 1985, and I'm an avid rower since my college years. And if you want to read why I do it, one of my crewmates now in California has written an article in the National Geographic, rowing is hugely beneficial for older women, and here is why I do it. My work at the Netherlands Cancer Institute, I want to acknowledge Piet Borst, who was the chairman of the board when I started molecular pathology, and he said the sky is the limit, and he was right. He came to a talk I gave, he's now 90 years old, he came to a talk I gave there 2 weeks ago. I told him, the sky is the limit, and you were right. And my people with whom I co-founded Arteaga, Bernard Six, René Bernard, and the people working there, in particular Anouska Glas, without whom there would be no Mama Print, and our current people working at Arteaga, and especially also Rena Phillip with the FDA, who worked with us through all of the approvals of the 70 gene test. Lastly, my UCSF work, Laura Esserman, my teammate, colleague, and friend. Nothing is too difficult. The UCSF Breast Oncology Program, Denise Wolf, who works with me on many things, what I do there, Lamorna Swigert, Melinda Walker, and also a very important part of our program is the breast science advocates. There are many of them are actually here, and here just all of those with whom I work day to day. Thank you very much.
Thank you. Thank you, Laura, for all you've done for patients with breast cancer. I'd like now to invite Dr. Shyam Goel, who will chair rapid fire session number 1.